Well, hello everyone. Welcome to another episode of Longevanity. We are just getting organized here and we'll be starting in a moment. I'm just waiting for the rest of my stream software to kick in, and I think we're all set there. So today we are going to chat about a slightly different topic. And I really want to focus a little bit of time and attention, particularly on women's health, and particularly what I want to refer to as medical misogyny. So, what's that? Well, so many times in different parts of our lives, women are being told, you're fine, when your whole life feels like it's falling apart. Have you ever been dismissed or minimized or told your symptoms are just stress? Well, then this episode may be for you. We are going to try to make this make a little bit of sense. Today, we're going to talk about something that has widely affected women, many women who I have met. And that is really this sort of hot or sensitive topic of medical misogyny. It's the quiet systemic bias that tells women that their symptoms aren't real, that their hormones don't matter, and that somehow their suffering is somewhat expected. Today, I want to pull the curtain back on how we got here. There is a history to this, and why this harm still happens, and what modern medicine should look like for women here in midlife. Women are not too complicated, and women are not being dramatic. Women have been under-researched historically, under-treated, under-listened to, and that era is now finally coming to an end. So this is where we're going to focus today. But again, before we really get started and get rolling, I just want to point out that our discussion topics here are really for educational purposes and aren't meant to be taken as personal health advice. These are really discussion points for you to arm you with tools so that you can go back to your own primary care provider and have these conversations, hopefully to get the answers you need, the care you need, and so rightly deserve. So today, let's kind of take a little look at what's been going on here. So the first thing I want to focus on is the root problem. Where did this come from? And this actually might surprise you, but women were never the default in medicine. Interesting. What do I mean by that? I'm talking about medical research. Up until about the last, 10 to 15 years, maybe a little bit beyond that, most women were actually actively excluded from medical trials. They weren't conducted, they weren't enrolled, and the trial didn't necessarily involve women at all. In fact, many drug trials actually avoided including women because we have some degree of unpredictability, and we could make their numbers messy. So because of that, a lot of the earlier studies up until the past, decade to 2 decades didn't even involve women. We were just extrapolated upon based on the outcomes we found in men. So again, female physiology was actually actively excluded and or ignored entirely. So again, all of our normal ranges from this previous era right up to very modern times are done based on male physiology without the inclusion of women until more recently. So again, some of the conclusions we've drawn from earlier work done may or may not have full relevance in women today. So again, this is something that is actively changing. But in order to understand what some of the inherent difficulties are, it's important to know how we got here. So how does medical misogyny show up in real life? Well, real life problems such as brain fog, sleep issues, libido changes, mood shifts, weight gain, PMS symptoms have been historically, and in many cases still are, being classified as just normal, just a stage of life, just stress. Maybe try yoga. Not that there's anything wrong with yoga, but we need to, of course, use that as part of a comprehensive plan that doesn't minimize a woman's symptoms. So again, perimenopause and menopause and some of these other symptoms that come along with them have sometimes been treated like a personality flaw or a weakness as opposed to a true medical system and symptom that accommodates some of the different changes that we're having. So again, women often feel dismissed, brushed aside, or minimized. And again, some of the diagnosis codes that we as physicians use as we do our OHIP billings and ICD codes don't even encompass some of these issues. So this explains why many times women are dismissed as just being anxious or stressed, and instead of being offered tailored specific treatments, are being offered things that are very much a band-aid fix, such as just an antidepressant. Again, there's a role for SSRIs in antidepressants, but that may not be in every aspect that they're currently being recommended. So we have to take these things into consideration. So what else has contributed to this? Well, in a couple of other podcasts, I've talked a little bit about the Women's Health Initiative. Initially, the Women's Health Initiative, which was a very large study back in about 2002, it was done to look at hormones and how they relate to disease prevention. Particularly, they were looking at cardiovascular disease, osteoporosis, Alzheimer's, and cancer risk. So this was a very large study of years ago that had many, many fundamental flaws when it came to the analysis. However, in 2002, the big headline that came out that has really heavily impacted women's health more than any other study in the last 10 to 15 years was this association made between the progestins, a synthetic hormone used as a mimic of natural progesterone, and the risk of breast cancer. And so all over in the media and in the medical journaling, there was a very, very large focus on this association that was with breast cancer. Now, subsequent to that, it became very clear that this was an issue more specifically with the progestin, the synthetic knockoff of progesterone, as opposed to bioidentical progesterone itself. And in fact, even in the Women's Health Initiative, the whole fact that estrogen was actually, the women who were getting estrogen actually had a lower risk of breast cancer, that was lost in the messaging of the study. And subsequent studies that came out again did not support some of the conclusions of the Women's Health Initiative, but it never got the media attention or the medical attention that that first headline did when they kind of threw the baby out with the bathwater, so to speak. So again, this has resulted in a full generation of women being yanked off of hormone replacement. So these are women who'd be like of my mother's age. So again, these would have been women who were in their 50s in the early 2000s, which is one of the reasons why we've seen a big increase in Alzheimer's disease, in women in particular, in osteoporosis, etc. So we are now revisiting the whole hormone story, but there's still quite a bit of misinformation out there, oodles of fear around it. And again, there's a very large educational piece that needs to happen in all elements of healthcare. So physicians, nurses, patients, everybody involved. So this is something that requires active work, but there was a real fear culture that was developed after the Women's Health Initiative, which still requires ongoing improvement today. Another issue as far as people feeling dismissed and written off is the whole concept of, oh, well, your labs are normal. So normal lab values require a little bit of education here as well too. So these again are population-based numbers. So there's statistics. So basically normal is sort of that 95% of people. So if you took blood values for any specific test and you plotted them out, there'd be like the median and then 2 standard deviations on either side. That's normal. So if you're in the bottom 2.5% or the top 2.5%, you are by definition abnormal. However, if you personally as an individual used to be, say, at the 90th percentile and now you're at the 10th percentile, you personally might feel very, very different, but your labs are normal. So again, we have to start to look a little bit at optimization and personalization rather than just a standard of care. So a term that we use a lot in medicine is standard of care and normal. And these are population statistics that are generated off of populations of people, but not individual recommendations for individual people with customization. And again, whether it's a podcast like this or any other type of talk, Individualization and customization is always key. This is why I always start and finish with the reminder that this is educational advice, not necessarily specific to you, but meant as a discussion point so you can get that personal care you need. So when it comes to lab values, there's a concept of normal that doesn't necessarily mean normal for you. It just means you're within 95% of the population in general. So optimization, personalization, these are very different topics that again may be relevant for you if you're having issues and symptoms and you feel very different and you're being told that your blood work is normal. So again, things to pursue and talk about with your own family doctor. Sometimes, again, people feel their symptoms are really minimized and brushed off because, again, they are normal. So, again, we have to be careful when we talk about standard of care and evidence-based guidelines. Yes, there's a role and a place for those things. Absolutely, I fully encourage and support and endorse that. But those are things that are relevant in population medicine, not individual medicine, individual personalization. So again, conceptually, I think there's work to be done here in order to create an environment that is ultimately most supportive for every person. Because quite frankly, for me, myself, I would much rather be treated as an individual and not just some population statistic. And I find that most of my patients would kind of feel the same way. You know, we're more than just a bunch of numbers and we want to feel our personal best for as long as possible as we can. So again, what are some of the costs of being dismissed? Part of the issue that we see, again, if we're not optimizing people's health and dismissing them, we miss things like, again, changes in body composition, loss of lean muscle mass and function, metabolic slowdown. So again, a lot of people complain as they get into midlife that they are exercising the same and eating the same, but they're putting on weight in different ways. And again, they're just told, well, just reduce your portion size, or are you sure you're really eating what you think you're eating? Well, there are some biochemical changes that happen at midlife. And again, the metabolic flexibility, your body's ability to switch from fuel source to fuel source. And what do I mean by that? Well, basically, humans consume 3 basic types of fuel. We consume carbohydrates that get broken down into glucose. We consume fatty acids or oils or fats. They get converted into little fatty acids. And we consume proteins, animal, plant, all proteins, they get converted into amino acids. So once these nutrients that come into our body eventually end up at the cells that they're supposed to supply and feed, we still need to process those things further in order to make them into actually usable components of energy. And that actually happens at my favorite little organelle, the mitochondria. And in there, there's actually a complex set of biochemical reactions that convert the actual food source, glucose, fatty acids, amino acids, into actual usable bits of cellular energy, ATP, for those little biochemistry nerds out there like me. So this is what needs to happen. But as we get older, we don't shift well from our carbohydrate burning into our fatty acid burning. And so again, this is why sometimes we see this midsection expansion, even with same diet and exercise levels. We just don't do that as well, and we have these metabolic issues that develop. So again, ignoring these sorts of things just frustrates patients. And again, it's almost like gaslighting them, because they're like, no, I'm telling you, I eat the same, I work out the same. Oh, no, you possibly don't. Or, just cut your portions or do this or do that. It's very, very frustrating, and it minimizes the patient's experience. So again, this really affects quality of life. This creates frustration. And again, a lot of times people just put up with it and become disenchanted with a system that doesn't support them. So the good news is that there is a definite cultural shift. Now, love social media or hate social media, to me, it's a double-edged sword. There's some very good points about it, and there's some harmful things. But the good points is that in reliable sources, social media is bringing more information to the masses in a faster and faster way than ever before. And patients and individuals out there are becoming more savvy all the time and more knowledgeable and are starting to advocate for themselves more. And this is really what I would encourage today. Today's topic really is more about being able to advocate for yourself than it is sort of the medical misogyny title that I kind of gave it at the beginning. As I think through it, as I talk here, I really want people to be empowered, understanding where we came from so that we can change our trajectory going forward. So we really want to encourage everyone, especially women, to advocate for change and just know that, again, a normal lab result doesn't necessarily minimize what you're experiencing at all. It just means that, again, you're within 95% of the population. And it's okay. And I would encourage you to demand more personalized care. We need to be able to create a change in the way our system takes care of us. And the only way to do that is going to be through advocacy. So again, better education for everyone, patients and physicians alike, will help us to create better health spans for people in the future. Again, I'm not here preaching living a longer life, although of course I wouldn't mind. But really what I want is I want the best possible health span for myself and for my patients, the highest quality of life for as long as I'm living. So again, to do that, we want to optimize, we want to personalize. So what does better care look like? Better care really looks like listening to symptoms, trying to use symptoms combined with personalized lab results to best and individually assess each patient. And we really want to look to do that, to harness things to try to create the best outcome for our patients going forward. We really want to look at trying to be more proactive in perimenopause and menopause. And we really want to consider it as both a metabolic, again, this metabolic flexibility, and a neurologic transition, not necessarily a hard endpoint. And we want to try to work towards creating more personalized plans that consider sleep, stress, metabolism, circadian rhythms, mood, and overall health, as well as sexual health too. And we need to take seriously the profound impact that these types of issues have on quality of life and trying to keep people feeling their best as possible for as long as possible. So what are some of the takeaways with all of this? Well, women, ladies, you're not being difficult. You are certainly not too complicated. You are not being dramatic. You have been under-researched, underrepresented in medical studies, and undertreated and under-listened to by the healthcare system. And that era, fortunately, is starting to come to an end. Hormone health is women's health. It is reasonable to ask for this type of care. And when you get proper care, you don't just survive midlife, you thrive. And again, you can't give from an empty cup. So as a primary caregiver to those around you, the family glue for your elderly parents, for your adult kids, who still need you, for your spouse, your co-workers, and all the other things you're called upon all the time. You really need to make sure you're advocating for yourself so that you can give to those. It's like the airline oxygen mask principle. You got to put your own mask on first. Then you can take care of others. So don't be afraid to advocate for yourself. And most of all, see what you can do to get out there, get the word out, support each other, and let's see what we can do to make a better, brighter future for all women and all people out there. So again, this has been our history, but it doesn't need to be our future. And if anything I'd like to do today is just really encourage you to advocate for yourself. You don't have to suffer in silence. If you've been feeling dismissed, if things have been told to you that they're just normal when you feel anything but, go back, ask again, be the persistent, pleasant, squeaky wheel. The system needs a little bit of time to catch up, but again, with advocacy across the board by everyone, we can make this happen a little bit faster and make it a better place for everyone. So that's the message for today. I used a few little cheat notes there. I was sort of messing with my papers on the side. I apologize if they were cutting into the screen, but I really wanted to touch on a few of those things, and I thought it was really important that I covered all those little details. So again, this is just general education. Please take this with what it's intended to be as educational advice. I would encourage you to speak with your physician or your nurse practitioner, your gynecologist, whoever you generally see. Don't be shy. Speak up, advocate for yourself. You don't have to put up with these symptoms. There are things that can be done. A lot of the old fears we had about hormone health, again, we need to challenge and revisit that. The new science does not support what was interpreted over 20 years ago. And so, again, it's time for you. So thank you so much for watching. And again, we're going to try to do these podcasts about once a week at lunchtime on Wednesdays. So if this is content that is interesting to you, I would encourage you to subscribe. I've got my little QR code there now. If you want to scan that, that will bring you into our subscription area. And if there are hot topics you would like to hear, I really want to keep these sessions meaningful and relevant to what's going on in all of our lives. Please feel free to reach out to me, and I would be very happy to try to take your questions and make it a topic for one of our little lunch hour meetings. We do have more information also on our website. So again, if you'd like to just check out a few details privately on the website, there's a little bit there around hormone health and some of the other things. This is our code for the website as well. So until next time, I wish all of you your best life. Get out there and do it. And I look forward to seeing you next